Welcome to this SCG Health Gimme 15-minute education program for medical professionals. My name is Jennifer Steerfoss, and I am the CEO of the Steerfoss Consulting Group. To help you spell my last name, the company is also called SCG Health. We opened our doors in 2011, and we focus our client services on revenue cycle management and strategic planning in this post-health reform world. This presentation will cover what you need to know about fee schedules. This session, along with many others, is available for free as a video archive on YouTube. SCG Health also offers in-person conferences on many topics, including ICD-10 preparedness, compliance, and EMR implementation. Learn more at scghealth.com. One quick legal note. None of the information contained in this presentation should be construed as legal advice. I encourage you to contact counsel if you have any questions regarding state or federal law that apply to the concepts covered in this session. With that, let's get started. We're going to start at a foundation covering accounts receivable. In this session, the accounts receivable will discuss and what that means, but also we'll get then into the fee schedules, which really is your allowable amounts and what you've contracted with health plans to cover. So what is accounts receivable? It is a concept that outside the medical community, it really is credit that's extended to clients, to folks that are coming in and receiving services. The problem is that in the concept of accounts receivable, it is the amount that is due for a medical service, the entire bill. And so, again, what we consider to be accounts receivable is the amount that is owed on an account, which could be the entire expected amount, which we also call an allowable. I'm going to talk a lot about allowables. But also, it's the patient payment that their out-of-pocket services and what they are paying for, and then the payment by the insurer if you're contracted with an insurer. So starting with what is accounts receivable, here's 4 example patients, and they've received $100 in services for 5 months, January through May. Now, depending upon the insurance that they have, it can be all over the place. So in the first example here, the insurance paid some amount and the patient has an out-of-pocket, totally different amount for the second patient. The third patient, the insurance has paid none of it and the patient is paid all of it. And then in your fourth one, which hopefully is not going on in your office, here no amounts have been collected by the patient. But the accounts receivable is the total amount that's due for all of your patients. And again, we normally dump them into different buckets. We have a 0 to 30, 31 to 60, 61 to 90, and then 91 to 120. Again, our goal is to never have anything that's anything large in that 120 or more bucket. So what this really looks like when you start looking at what patients have is that depending on, again, the type of insurance that they have, and here's 3 private insurance patients and a Medicare patient, is that you're going to have dollars and cents that are due on different portions. Part of it may be the contracted rate from the insurance plan, but also the patient may also owe money. So always keep in mind that when you're looking at accounts receivable, it is a blending of all of those amounts. To do this well, you have to know what your contracted rate is, and we're going to talk more about that. So you have to have timely, accurate information on what your insurance allowables are, but also then you're going to need to ensure that your staff understands their role in your success. Their role as a front office staff person is that they are going to talk to the patient and have them understand what their out-of-pocket expectations are. The back office is to collect all the insurance amounts that are due and work with the health plans to receive that timely. Then the clinicians, again, they also have to have a role in this because if they don't want to talk about money, guess what? Your doors can't stay open. And obviously patients need to have some role in this too because they are going to need to understand their role, again, in your success. If you've never spent time with any of your accounts, I highly recommend you check out the Medical Group Management Association's chart of accounts. Very, very helpful as you're actually doing your accounting aspects for accounts receivable and ensuring that all of your tax information is collected correctly. It is on its 5th edition, which came out in 2011, and it's a standardized list that you can either use in your accounting software or something that your CPAs can work with. So with that background, let's move into fee schedules. If you've never heard of a fee schedule before, you may have heard of allowables, as I mentioned. For Medicare, I highly recommend you go and check out the cms.hhs.gov portal where it has a lookup. You can look up either a series of codes or specific codes and know for your locality what you get paid. Medicare does pay based off of GPCI. They adjust the payments for what's known as a geographic practice cost indices, the GPCIs. And so your payment may be different depending on where you are located. Most inner city or urban areas have a separate GPCI than the rest of the state. So it just depends on where you're located. If you're familiar with your local area contractor, which are known as MACs, they also have an Excel spreadsheet that you can download, and usually that Excel can be straight uploaded into your practice management system so you know your rate. Health plans are not as helpful. Oftentimes, they're going to have a long list of all of the codes that you're paid, and it either is going to be in paper format. A couple of them do have it in Excel, but really what's going to have to be figured out for you is what you're going to get paid. Now, please keep in mind that there are different rates for facility and non-facility. This is true for Medicare and the private insurance plans. So as you're looking at your fee schedule rate, make sure, dependent upon the place of service, that you choose the correct item. So if you're performing services in the office, which is place of service 11, you are then going to choose the non-facility rate. If you're performing services, professional services in an ASC or in a hospital setting, that's site of service, off the top of my head, I want to say 23 or 24, then you're going to choose the facility setting. So just make sure you choose the right rate. And then remember, private health plans have multiple products, which means that they will have a different fee schedule for the different products unless stated otherwise. So for example here, the fee schedule on your right-hand side includes a PPO and an HMO product. And so those are two different rates depending on, again, what patient is presenting. Those are your total allowable amounts, which means that patient out-of-pocket share is not included in that amount, or it is included, meaning that the totality is the allowable amount. So what you have to figure out is your fee schedule amount as that you're allowable. What is the patient coinsurance, which includes the deductible and the copayment, and then the insurance is going to pay what's left. So for the example I normally use in all of my presentations for Dr. Happy, for Dr. Happy here we have a E&M service, a level 3 established patient E&M service, and then a scope. And the charges, again, we've come up with these other Gimme 15-minute presentations have talked about setting your charges, but the Medicare allowable 7308 for the established service, that, by the way, is a national rate. Charges are $150. But if it's if it's a patient coming in at the beginning of the year, they likely have their deductible. And the Medicare deductible for 2014 and 2015 is $147. So if the patient hasn't met the deductible, that entire amount is going to be collected from the patient, the $73. And then there's going to be a portion for the scope that's going to be collected. Now, just a quick note about Medicare patients. You never know if they have secondary, and the secondary insurance may be picking up the deductible. So whether or not you collect out-of-patient at the time of service amounts from the patient, that's up to you on Medicare. But for any private insurance patient, absolutely you can collect this amount. I highly, highly, highly recommend it because once that money walks out the door, you're likely not going to get it back. So let's say that the patient has met the deductible. In this instance, again, looking at Medicare, what's going to end up happening is that the patient is going to pay a certain portion of it, which again, traditional Medicare is 20%. That's what they're going to pay. And then the amount that would be going to the patient in this instance is $112.82. Now, once the patient deductible has been met, the 80% is subject to the sequester. So the 80% would be discounted to $88.47 with the remainder due from the patient up to the $112.82 because guess what? You have a 2% sequester discount that cannot be balance billed to the patient. So hopefully, if nothing else, you have now a new understanding of the fee schedules that are available to you, the importance of knowing what your allowable amounts are so that you can calculate the patient out-of-pocket, especially at the time of service, which is a best practice, and again, that you have a better understanding of how to operate with your workflow in your medical practice. So with that, I hope you've enjoyed this presentation. For those of you watching in the video archive, please remember to rate this video. To receive notices about upcoming Gimme 15-minute programs or other educational sessions, please sign up on scghealth.com. Thank you for joining me for this 15-minute education program. This concludes the presentation.